Good afternoon. As a couple of words of introduction, as Jamie mentions, I work for an organisation called the International HIV/AIDS Alliance. So we're an international civil society organisation, a network of civil society organisations working on HIV in 40 developing and middle-income countries. In 9 of those 40 countries, we do harm reduction programming. I also want to say by way of introduction that the topic that I'm speaking to today is based on some joint work between ourselves and Harm Reduction International and IDPC. So it's very much a joint set of analysis about harm reduction spending globally. My presentation is not directly about Europe, but I assert for 3 reasons it's relevant to a European Harm Reduction Conference. The first assertion is that, and it's a really important one, that developments, the thresholds and the new frontiers for harm reduction in Europe lead the world. I say that as someone who's trying to establish harm reduction programming in developing countries. We talk about harm reduction programs in Switzerland, and in Germany, and in the UK all the time. So as you reflect on your struggles in your own European nations, I want to remind you that the work that those of you who are working on the harm reduction front lines are doing in Europe is an inspiration for the world. Second point is that the harm reduction financing issues that I'm going to speak to do refer to the development of harm reduction in Eastern Europe. Peter will talk about those developments more specifically, but Eastern Europe and development financing for harm reduction in Eastern Europe is very much part of our gaze. And finally, I kind of remind everybody of the obvious thing, which is that Europe is also a development donor. The European Commission is a major and important international development donor, and as such funds harm reduction in developing countries, and as indeed do European member states. So I think I assert it's important to consider Europe as a donor of harm reduction in other parts of the world. So, without further ado, I wanted to talk about the global need for harm reduction services. Just a reminder for you, most of you, I predict in this room, will already know these basic figures, but I just want to set the scene that there's 16 million people, estimated 16 million who inject drugs worldwide. Estimated 3 million of those who inject drugs are living with HIV. Don't need to remind people in this room that there's very high rates of hepatitis C amongst injectors, and the coverage of services, harm reduction services in low and middle income countries, is officially defined as very low by UNAIDS. Access to treatment for both HIV and for hepatitis C is very poor for drug users in low and middle income countries. And that HIV is on the rise in many low income, amongst people who inject drugs in many low income countries, including in new settings such as East Africa and West Africa. The final kind of setting the scene point that I want to make, that I'll speak to more directly, is that there are changing trends in the way HIV and international development are financed, and that's impacting on harm reduction. In 2011, UNAIDS developed a model for ending AIDS, which became known as the investment framework. So they're based on kind of current spending on HIV and current impact, the impact of current HIV spending. They calculated that by 2020, in order to end AIDS, our investment in highly targeted evidence-based interventions would need to rapidly increase. And you'll see from this slide that by next year, based on this modelling, UNAIDS and others, WHO, concluded that $2.3 billion was needed in 2015 itself in order to end AIDS amongst people who inject drugs. So just remember that figure, it's 2.3 billion is the estimate estimate of what's needed next year to end AIDS amongst people who inject drugs. The big important stakeholder on the landscape of global funding for harm reduction is the Global Fund for HIV, AIDS, TB and malaria. It spent an estimated $595 million on harm reduction programming since round one. So for those of you who are unfamiliar with the Global Fund, it used to work by a series of rounds that were broadly fitted with each year. So over about a 10-year period, the Global Fund's invested about $600 million in Global Fund in harm reduction programming, which makes it the largest harm reduction donor in the world. 147 grants, 58 countries. Importantly, the Global Fund is changing its rules, it's changing its policy on how it funds AIDS, TB and malaria programs, and that's affecting or about to affect harm reduction. We'll speak about that a bit more. So just to give you an indication of the kind of the trend of the funding by around 10, which was in 2010, is that right, Jamie? There was a substantial investment in harm reduction from the Global Fund, and we started to see the effect of this in a number of prominent countries, such as Indonesia and Vietnam and China, elsewhere. Really substantial money for really large-scale programming for the first time ever. All good so far? Now I want to kind of talk to the issue of how the funding policy is changing. And it's important to assert also that as the Global Fund policy on funding AIDS changes, it merely reflects a wider trend in donor funding for AIDS and for health and development more generally, and it's about the middle-income country problem. It's a particular problem for people who inject drugs, a particular problem for harm reduction, because many of the high-priority countries for harm reduction, the countries where there are the largest numbers of people who inject drugs who desperately need harm reduction services, many of those countries are now classified as middle-income countries. So they include countries such as China and Brazil, that some of you would predict, but it also includes countries such as Malaysia and Thailand. And so these are countries that are increasingly becoming ineligible for any development financing, including Global Fund financing. And so these are countries with really, really large numbers of people who inject drugs who have either never received harm reduction services before or who have just started to receive harm reduction services that are paid for by international donors. So these countries are becoming ineligible. The countries where there's a lot of a reduction in funding and where there's a lot of lack of clarity about the future of international funding for harm reduction are again some of the other really big countries in terms of people who inject drugs who need harm reduction services. India, Indonesia, Pakistan, Ukraine, Vietnam, all really large HIV epidemics amongst people who inject drugs. And so the status of the financing for those countries is very much under threat. Low-income countries is where the trend for development financing is going, no surprises there. But in terms of what that means for harm reduction, Kenya and increasingly countries like Tanzania, Nigeria, well, Nigeria is not a low-income country, but anyway, it's countries where there are emerging epidemics amongst injectors and where the countries are formally classified as low-income, which was where investments, international development investments will be maintained or in fact may increase. It's just a slide. It's not very scientific, but just to give you a kind of a snapshot picture about where the money is in terms of international development financing, including money for HIV, harm reduction, the trend is towards Southern Africa, Southern Eastern Africa. Just to A few comments on the Global Fund new funding model. It sets ceilings for countries. It's the first time that that's happened in the history of the Global Fund. It's saying, you know, only so much for this country and that country. That has a dramatic effect on countries in particular in that middle band, such as Ukraine, Vietnam, Indonesia. There's a ceiling now, whereas previously countries could go to the Global Fund with an expansive plan to say, this is how we want to stop HIV amongst people who inject drugs. This is how much we need. That's no longer the case. There's now a ceiling set, and there's this issue about eligible and ineligible that I referred to previously. In some of those countries in that lower middle income country bracket, there's a very unfortunate use of the term over-allocated to describe the countries that have received harm reduction investments previously. The case that I know best is Ukraine. My colleagues run the largest harm reduction program in that part of the world, in Ukraine, funded almost entirely by the Global Fund. It's reaching about 50 to 55% of people who inject drugs in Ukraine. Now, we know from WHO modelling that in order to have significant impact on the HIV dynamics of a nation's epidemic, harm reduction services coverage levels need to be about 60%. So we haven't got to what WHO have defined as the kind of level of coverage in order to have a significant impact on the HIV dynamics. However, you can start to see some impact. There is some HIV impacts on already this substantial investment in the Ukraine harm reduction program. However, that's now being defined as over-allocated, and the money for harm reduction in Ukraine will go down. Of the way that the countries have been carved up by the Global Fund now, of the 58 countries that have received Global Fund funding for harm reduction, 14 of those are now ineligible for Global Fund funding at all, and 10 of those will receive no new money for harm reduction. And the calculation for the spend for the next year on harm reduction from the Global Fund under the new funding model is 64 million. So compare that figure. So this is the largest donor for harm reduction in the world. UNAIDS and WHO calculated it was 2.3 billion that was needed next year to end HIV amongst injecting drug users, and the Global Fund is predicted to spend about 64 million. So you can see the shortfall. Of course, that then leads to a set of questions about domestic funding for harm reduction. And increasingly, the challenge for all of us who want to expand harm reduction services to people who inject drugs, particularly in poor countries, will be the effort that's required now to convince national governments that it's their responsibility to invest their money in harm reduction. Oops. Okay, final slide. Just to let you know, to kind of kick off the discussion really, the advocacy agenda that many of us working in HRI, IDPC, Input, other organisations, is Eurasian Harm Reduction Network, importantly, is to begin to track domestic investments in harm reduction. We need to be understanding more how much nations are spending on their own harm reduction programming. Building capacity for civil society in these kind of important countries such as Vietnam, Ukraine, Indonesia, to advocate for domestic resources for harm reduction, and also an advocacy effort to try to keep the Global Fund global so that it doesn't necessarily follow the trend of other development financing, but that the uniqueness of the Global Fund is maintained so that it's funding HIV, TB, malaria programming where it's needed, not just where, so that the income country status is not the only variable that defines how its funding model. So just to close, I've said it before, I'll say it again, that the European harm reduction responses to HIV amongst people who inject drugs, I kind of presume that many of you barely think about the successes that have been achieved in Europe in terms of preventing HIV amongst people who inject drugs in many European states. The successes that people like you have been part of that are about accelerating people who inject drugs as access to antiretroviral treatment. These kinds of successes are both, as well as hard won, and it's important that we hold those lines. Just a reminder to you that those successes remain an inspiration to all of us that are working in developing countries, and keep up the good work.